like Jason said, this is my dad, Dr. Douglas Anderson. He went to medical school at the University of Utah and then did his residency training in otolaryngology, or ENT, at Indiana University. And so he's been practicing here in Ogden for 19 years, and I'll let him get started.
Well, I'm honored to be able to speak to you today. It's amazing, but it really doesn't seem like that long ago that I was in your same shoes and getting ready to apply to medical school and excited about it and wondering what specialty I wanted to go into. And in high school, I really loved sports and athletics, and I always had thought about doing orthopedics, and I did something totally different. And so I would just say one recommendation that I would have for you is to keep your minds open, and as you go through the different rotations during your third or fourth year, clinical years, you may like something that you didn't think. And one thing that's exciting is that in medicine, there's so many exciting things. Even in, if you did family practice, I remember that was one of my favorite rotations too, just because you could see so much and do so much. But even if you subspecialize, it's amazing what you can see in just a small specialty. I ended up going into ear, nose, and throat just because I thought amazingly, even though it's a small part of the body, there's a lot of variety. There's a lot of different kinds of surgery, from very simple to very complex and complicated. And you see the whole gamut of patient ages. I didn't want to get stuck doing just old patients or young patients. I wanted to do a little bit of everything, and so it really seemed to click with me. So I would just recommend that you just keep your minds open. One thing about ENT, it's ear, nose, and throat, or otolaryngology, head and neck surgery. We could do a lecture on many different aspects of ear, nose, and throat. We could do a lecture on sinuses and allergies. We could do a lecture just on ears. We could do a lecture on head and neck cancers. So there's a lot of different things. But today, I thought I'd talk a little bit about the oral cavity and some surrounding areas, just because I thought I'd show you there's a lot of interesting things just on that small area of the body. And it's amazing how many illnesses have manifestations just in that area of the body, just in the mouth or lips. It would help you diagnose something that's going on elsewhere in the body. And the other thing, this is a lecture I gave several years ago for some local dentists, and again, just to show to them that there's a lot of things that they can pick up just looking at the teeth. Now, I don't know if any of you are thinking of going into oral surgery or dentistry, or maybe it's just all medicine, but there's a lot of interesting pathology that even dentists can pick up. But go ahead. And so a couple lessons I think there's a couple lessons I think you want to learn in medicine. Is sometimes you can be so focused on the most common things that you may miss something that is maybe just a little outside of your specialty and may have a little manifestation. So you have to sort of have to be aware of other things that go on. So for example, if you became an ear, nose, and throat physician, you couldn't be so focused on that that you wouldn't recognize manifestations of another systemic problem that may have a small little presentation in the mouth or somewhere in the head and neck area. I remember when I was in medical school, we had a patient that had testicular cancer, and so lots of times they'd give the medical students time to go in and do a thorough physical, probably a lot more time than the residents had. And so I read up on it. I was really nervous about it, and I learned that people with testicular cancer could have lymph nodes in what's called Vercos lymph node right up here in this supraclavicular area. And so I read about that, and so I went up and I examined the guy, and sure enough, he had a big old lymph node right there. And I remember I was so excited because the resident hadn't even picked that up. And so sometimes if you sort of are looking at other things, other manifestations outside your areas of expertise, you may find some neat manifestations. So this is a little bit of a funny video that may show how if you're so focused on just your area, you may get burned a little bit. So you just have to be aware that other things may, just outside your specialty, may be looking to keep that in mind. And then the other thing that's an important lesson to learn is that you always have to have a differential diagnosis. Sometimes, whatever specialty you go into, you can get caught in the trap that you see a ton of ear infections, you see a ton of sinus infections, and so pretty soon everything seems to be an ear infection. And I remember there was one patient I had that was referred to me for ear infection. She had recurrent ear infections, and so I saw her, put some tubes in, and she actually did well for a while, and then started to have some drainage, and we put her on some ear drops, and then she decided to go, didn't come back, went to someone else, but then several years later, it ended up being that she had a cholesteatoma, which is a cyst, and so that was always a great lesson to me that sometimes it's, you know, even though you may see zillions of kids with ear infections, for example, it may be something else is going on. So you have to have a differential diagnosis. It's not always just cut and dried. You have to think in your mind, what are some possibilities that this could be that this patient has? And then always keep your eye out for those other things that are not so common, because otherwise you're going to get burned. And so this is another little funny, and it just shows that sometimes it may not be as it appears. It may be something different.
There's a man who leads a life of danger. Everyone he meets, he stays a stranger. Every move he makes, every chance he takes, all he wants.
So anyway, but it is true in medicine. Sometimes you have to keep a differential diagnosis and keep other things in mind. Next slide. So a couple things, you know, when I was in medical school, we were always taught as I was preparing to take my boards that you have to keep in mind as you're making a differential diagnosis, you know, what's the timing, how long has it been? I mean, it could be that a lump in the neck could be a tumor, could be infection, could be an autoimmune thing. You just have to keep in mind what are the broad different categories and things that it could be, and things that help you decide what category it should be in. Would be timing, how long they had it. Has it been slow growing, fast growing? Is it painful? You know, lots of times inflammatory things are more painful. Sometimes things that are slow growing, not really painful, could be something more serious. Social history, what's their social history? You'll see some slides later on. Have they been a smoker? What's their, you know, are they promiscuous? Have they had trauma to the area? Maybe there's been some trauma. Are there signs of infection such as fever, swelling, fluctuance? Have they been on any medications that have a side effect that could cause a reaction? Or maybe do they have an allergy? And then the other thing is are there lesions elsewhere in the body that may give you a clue of what's going on? Next slide. So I'm just going to show you some quick slides of some things that you can see in the mouth. But maybe there's some things you may look at these and say, gosh, I've got that myself. But anyway, this is a really common thing that we see. Lots of times you'll see people that come in, especially students, when you're having stressful times, you're studying, you're staying up late, you may notice that your tongue may have like red patches and white patches, and it may be that it's changing. And we often will have people come into our office saying, I think I've got some sort of a disease going on. This is a common presentation. It's called geographic tongue. And it's not painful, but occasionally it can be painful. And those little patches, they can be circular, they can be all over the place, or they can be just smaller. But anyway, it's nothing to worry about. And honestly, the cause is not necessarily known, but stress may play a part of it. But go ahead, next slide. This is a picture of someone's tongue, and I remember I was referred to a patient very similar to this from a dermatologist who was worried that maybe this was some sort of a tumor here, because it looked almost like papillary type thing, that they were like little fronds, little things that were so different than the rest than a normal looking tongue. And so we did a biopsy, but this is actually called scrotal tongue. And the one thing that it makes it different from like someone that has a tumor is, you know, it's diffused. There's no like one area that's a growth and the rest is normal. It's just diffused out. And so this is a scrotal tongue, and some people have those. It's not to worry about. Next slide. And so this is an interesting thing. Some people may come in and say, gosh, I've got these bumps here. But actually, These, if anyone has an idea what caused these scallops, does anyone have an idea? So this is just a person with a large tongue, and these are little indentations of teeth, where the teeth sit. And so, but anyway, so you just got to keep that in mind. But that's a crenated tongue, it's called. Next slide. And it's sometimes color may throw you off a little bit. To one person, this seemed like some sort of a disease that was growing, almost like a vegetation. But really, those are just the venous. The blue color of the venous blood in the veins there at the side of the tongue. And for some people, it's maybe a little more prominent than others. Next slide. Now, does anyone notice a difference of this tongue compared to some other tongues? Does it look a little different to you? Does anyone want to throw out some thoughts?
Orange.
Dry.
So a little orange. What else did someone say?
Dry.
Dry, very dry. So this is a person who has a very dry tongue, and it's almost leathery looking. And this is a person that has Sjogren's disease, which is sort of a disease that's a little bit like in the family of rheumatoid arthritis or lupus. But anyway, the body produces an immune response or an attack on the salivary glands, the glands that produce mucus. So their mouth is very, very dry, and so they may have swollen glands because of the inflammation, but they also have very dry mouth and very dry eyes. And so anyway, this is typical of what a person with Sjogren's disease looks like. This is a very interesting thing. This is a hairy tongue. You may think, oh my gosh, what is going on there? But anyway, this is often seen in people that aren't taking very good care of their mouth as far as oral hygiene, but it also can be seen in people that are taking a lot of Pepto-Bismol, or people that are using hydrogen peroxide in their mouth. But things like that may make them prone to get this hairy tongue. And it's not really, basically it's what is the normal, the tongue has papilla, little tiny little extensions, little like hair prongs that stick up on your tongue. But these are grown really long, and then they sometimes change color because of food or bacteria. But it's not anything bad, and usually if you improve your hygiene of your mouth or stop drinking Pepto-Bismol, it usually goes away. So. This is another picture of a hairy tongue, and this one's whitish, and this is more normal tongue here, but these are just sort of long, really thick, hairy growths of the tongue. Next slide. This is just to show you, most people know about tonsils, and so we have some people come in and say that I've had my tonsils out, but I've got this sore throat, I feel like I have a lump in the back of the throat, and they stick their tongue out. So this person is sticking their tongue out, and we've pushed it down, so the tongue is out this way. And these are mounds on the back side of the tongue, and these are mounds of tonsil-like tissue called lingual tonsils. And so a lot of people don't realize that on the back of your tongue you actually have this circular ring of lymphoid or tonsil-like tissue called Wildeyer's rings. And so, the tonsils, many of you have had removed, are sitting over here. Your adenoids are behind the uvula up here, and then the lingual tonsils on the back of the tongue are here. Some people don't have much in the way of lingual tonsils, but other people have these huge mounds that look like another set of tonsils. Next slide. Some people have little mounds of tiny tonsil-like tissue as part of that Wildeyer's ring on the sides of the tongue. And for some people, it may look like a growth or a tumor. So again, some of these all look alike. And so as you'll see some pictures of some tumors later on, they'll say, how do you know? And sometimes you may not know. You may have to biopsy. So again, you have to keep a differential diagnosis. Could it be inflammatory? Could it be just a normal variant? Could it be a tumor? Could it be autoimmune? So you just keep those general categories in mind, and if you do that, that'll help you with your differential diagnosis. So this is someone who's, again, stuck out their tongue. Their tongue's coming out this way. These are the tonsils up here. The uvula is up here, and this is on the very back, sort of where you saw those lingual tonsils. But this seems different. It's smooth, covered, and it's sort of a whitish color. Any thoughts what that would be? That is actually, when you're in the mother's womb, so this is why medicine is so exciting, but when you're in the mother's womb, you sort of wonder, gosh, where would I use all these things when I study about embryology or things like that? When you're in the mother's womb, the thyroid tissue actually starts in the base of the tongue, and then it descends down to its position by the time you're born. But sometimes along the way, maybe it doesn't descend like it should, or maybe there's a cyst that stays here instead of down here. And so this is called a lingual thyroid. So you need to be worried about that. Gosh, if you just went and cut that out, that person may have no thyroid function after. So you at least need to be aware of what that is and have that in mind before you just take it out. So So this is an interesting thing. This is maybe hard to see, but you see these teeth right here? These would be the molars on it. So you're looking at the roof of the mouth, and the front of the teeth would be up there, incisors. These are molars on the other side. The uvula would be down here, soft palate, hard palate up here. And so you see, here's the hard palate, and this side has this whitish ulceration lesion that comes over the midline. And I'm going to tell you this, and this person is very painful. And this side, it's normal. Any thoughts of what could come over one side of the body? Maybe some of you have had that. But this is shingles. So, you know, it's hard to say because, you know, there are lots of people have, like, you've heard of cankers or herpes blisters or cold sores or things like that. And yet, so you have to think of all those things, but something that comes over just at the midline and stops, you think of shingles. So next, herpes zoster. So here's another one, and I know that what tells you what it is right there, but again, so it comes over the middle of the lip and stops. This side's okay. So that's it. So here's one. You've all heard of just the herpes simplex cold sores. You know, it's all around the lips on both sides, and so that's cold sores. Again, cold sores again here on the one side of the mouth. But you have to be careful because sometimes that could be a sign of something else. You know, you think of, could it be a viral thing, herpes simplex, or could it be like a staph thing like impetigo? Maybe you've heard of impetigo, or could it be a cancer thing? I'll show you one later on. Cancer, they thought it was a cold sore, and he just let it grow and grow and grow, and it ended up being a cancer. Go ahead, next slide. And so this, maybe some of you have had this. This is from biting the inside of the lip. So here's the lip out here. Here's some teeth here, but this is just next to the oral commissure on the inside of the cheek, and inside the cheek. And it's right here that he's bit that, and he's got what's called a traumatic fibroma. He's, I'm sorry. This is actually, this is an aphthous ulcer, and so some people call those canker sores. I'm sorry, I didn't see it very well. But that's an aphthous ulcer, and those can come. We don't really know the cause of those. It may be during times of stress. For females, it may come during times of menses. It could be due to mechanical trauma from brushing or biting. They're very painful, called canker sores, and but often they go away on their own. Sometimes you need to coat them with a little steroid or something to help make them go away. But they're aphthous ulcers, and for some people they can be very miserable. Next slide. Some people get them on the back of the throat. I've seen them down by the epiglottis down below, but they can be on they're usually on the soft tissues of inside of the lip or on the soft palate, and even down by can be down on the back of the throat by the epiglottis. They're very painful. They're usually self-limited. This is what's called angioedema, and this, again, differential diagnosis is so important in medicine, and that's why ENT is so interesting, because they thought there's such a variety. It's not just tonsils and tubes and sinuses, there's a lot of variety. This is called angioedema, and there's different causes. Some people could be an allergic reaction to a medication they're taking. ACE inhibitors is an example of blood pressure medicine. Sometimes it can be due to allergic to foods, such as peanuts or something like that. And some people are genetically have a defect in their system that they get an inflammatory response. It just comes on suddenly. They'll have swelling of their lips or their tongue may swell up, and or maybe around their eyes. And so you have to keep in mind all these different things. So angioneurotic edema is the one that's more a genetic thing. It's common in the Midwest among blacks, and so you have to sort of be aware of that wherever you're at. Next slide. This is a cyst right here called a mucocele. So inside your lip, you're not aware of it, but you have hundreds of minor salivary glands and little tiny granules underneath the mucosa of the lip. And if you bite them, they're little. It's really literally like a little sunflower seed, but rounder, and they have little hair-like extensions that go up to the surface. And if those hair-like extensions are ruptured, whether through biting or brushing or some mechanical trauma, that gland still produces mucus, and it leaks out and causes this blister to form. Sometimes they rupture, or you bite them and it drains, and then it heals over and then it comes back. And ultimately, the treatment is to excise the little granule underneath, in addition to that cyst, before it goes away. So next slide. So here's another one. So your mouth has tons of salivary glands. You have major salivary glands, and carotids, and sublingual glands. And you have hundreds of minor salivary glands, but you also have these ridges along the floor of your mouth called sublingual, the sublingual glands underneath. And they, same thing, have these hair-like extensions that come to the surface, and if they're traumatized, you can get what's called a ranula. And so, the same thing, if you go in and drain that, you'll get a ton of, it looks like mucousy fluid that comes out, but as soon as it heals over, that little puncture site, it swells back up again. So you actually have to excise and take out the whole gland with it. Some people just take off the top and leave an open surface, that frequently that'll close back over, and so really to totally cure, you have to go down and take out the whole gland underneath. And so here's another form of the same thing. Next slide. And here's an interesting thing. So you have these little ducts that come from the submandibular gland. So the tongue is that way. That's the lingual frenulum underneath the tongue. The lower lips would be down here in the teeth. And this is a white thing right there. That's a stone in the gland, the duct that comes from the submandibular gland, the Morgan's duct. That will cause swelling underneath the jaw here. And so you have to think, gosh, what's causing swelling right there? Look inside the mouth, and that's the cause right there. This is an interesting thing. You see this? This is the uvula right here. Can you see that? And this is almost like a double uvula with a little crease inside here. And so that's really important for a ear, nose, and throat physician, because the eustachian tubes, when you yawn or swallow, there's a sling of muscle that goes from here across to the other side. And that's what pulls on the eustachian tube to open up the eustachian tube. So in people that have this kind of deformity, it's like the mildest form of a cleft palate. And so their eustachian tubes don't work well, and so they have ear infections. And the thing that's also important with that is because that, you know, when you say the word P, it doesn't come out your nose because that sling of muscle goes back and touches the back of your throat, so the air doesn't leak out your nose. But when people that have this deformity, if you were to take out their adenoids, it has to go back further. It's harder to do, and they would sound hypernasal. So you'd be going in there, taking out the adenoids, thinking everything's fine, and they come out, and it's a sort of embarrassing thing. So you have to be aware of what you're doing and what you do. So next slide. This is a painless lesion on the lip or around the mouth. Could be anywhere, actually. It could be in the mouth. But you can see this little dark thing. That is a syphilis chancre. And so most of these things that I'm telling you about, these are things I've actually seen in my practice. And so you see, it's surprising. So anyway, so this wasn't a cold sore or blister, and this was a painless lesion. And so we did a little blood test and found out that he had syphilis, but it's very treatable with amoxicillin. Next slide. And he had I've never seen one here, but this is the same thing right here on the tongue. So this is a condyloma, so it's a genital wart that can present in the mouth. And so again, knowing their social history and their life, what stage, what they're doing in life is important. But anyway, so that's what this is here. So does anyone know what Addison's disease is? What's the Addison's?
It's just an autoimmune disease that affects the adrenal gland.
Right, yeah, so it could be autoimmune, could be other, something that makes the adrenal glands not work well. Could be trauma, could be a neoplasm, I guess, but anyway, it affects the adrenal, the outer cortex, the adrenal cortex of the adrenal gland, and that's responsible for producing cortisol and mineralocorticoids, which are responsible for salt, sodium and potassium in your body concentrations. But anyway, these people get these brownish things in the mucosa. And can you think of anyone famous that had Addison's disease?
JFK.
JFK, exactly. So that's really interesting. Next slide. So this is someone who's been on some chemotherapy. People that have bad arthritis on methotrexate or something like that. They get sores in their mouth. So again, just sort of understanding what they're being treated for. Also, why do they have these sores in their mouth, and understanding that it could be causing that. Next slide. And same thing in the slide. It's on the inside of the cheek. Next slide. This is someone who came in and had it looked like a tumor right here on the gums. This is a person that tongue's over here, the lips down here, and she wore dentures. And so it looks exactly like it'd be a neoplasm. When the person I saw, this is something different, but had a bigger one here. And so we just said, don't wear your dentures for a while, and it went away. So we didn't even biopsy it, and it went away. But you still have to think, gosh, if it doesn't get better, you got to come back and biopsy. So this is the one I talked about earlier. This is for biting the inside of the lip. Here's the teeth, and the lip is sprouting out here. And so they bit me and just easily, it's a traumatic fibroma. So can anyone decide what this is? I guess you can't. That's the tonsils. Here's the uvula, big tonsil, big tonsil. This is what we call kissing tonsils, so there's not a lot of room to breathe through. Tongue's down here, it's being pushed down. But that person is not going to breathe very well, so you have to watch them carefully and probably need their tonsils out unless they respond dramatically to medicine and steroids, like antibiotics and steroids or oral. Excellent. So this is a different presentation, very similar thing. So this side, here's the uvula, comes down here. Here's the part of the soft palate of the uvula and the tonsil here. But look at this soft palate here, how big it is. It's swollen. This is what we call a peritonsillar abscess. And see how the tonsil down here is pushed way down, whereas this tonsil's up here. So something is pushing down the tonsil there. And so we would just put a little needle or a little incision right here and usually drain out 5 or 10 cc's of pure enough material from that. So it's pretty impressive. So this is, you guys maybe had some of this before, but some people who lick their lips a lot, or especially kids, get really bright lips and bright mouth, and they maybe get a crack here, and they'll get a little infection, whether it could be a little fungus or it could be a little staph infection, and so we treat it with an antibiotic ointment and a little antifungal, and usually get better really easily. So this is a person that had dentures, and in the mouth, they took out their dentures, and they had all these red, sort of painful spots in their mouth, and that is an example of a little fungal infection in Candida. Excellent. And so one thing that you can determine, so fungal infection, you think of, could it be, there's different things that look very similar. There's lichen planus, there's leukoplakia, which is a big cancer lesion, but there's fungus. And one thing about fungus is you can see out here, you can just scrape it off, and it'll come off a little bit. Excellent. But it still leaves little red dots underneath, like that palate. That stuff's come off. So that's fungus, basically. Next slide. This is a person that had bad tonsillitis, came in and put on antibiotics, but didn't get better. In fact, they got a rash, got worse, got fevers, and swollen lymph glands in the neck. Any thoughts what that could be? What's that? Mono, exactly. So mono can look like that. It will look just like a tonsil infection. It has white exudate on the tonsils. They have swollen glands. They have fever often. They often get a rash if you put them on amoxicillin, and they're tired. And anyway, that's mono. Same thing again. And so this is called erythema multiforme or Stevens-Johnson syndrome. What that means is basically they get sores most of the time in their eyes, around their eyes, and their mouth, two mucosal surfaces. They can also have lesions elsewhere in the body. And so, here's an example. They're sort of like target lesions that are, you see these little red dots in the middle, lighter, and a little red ring around the end. And so that's Stevens-Johnson syndrome. This is, it could be from trauma, but it's a granuloma, pyogenic granuloma. Sometimes you can get those during pregnancy. That's sort of an interesting thing. And this is the same thing on the side of the tongue, probably biting the tongue. This is an interesting thing. This is called necrotizing alloneoplasia. This can be scary to a lot of people. What caused that or something like that. But that could be due to trauma. For example, someone who, so that's the palate. Our palate is like there's been a hole, a real well-circumscribed hole that goes right through the mucosa down to the bone. But usually that is from either an injection with some lidocaine or something like that, somebody with an injection to numb something up, or just from trauma, from intubating a patient, putting a breathing tube in during surgery, and that can happen. And they go away from that. So this is an interesting thing. You see these little whitish things on the inside of the mouth, and they look sort of ominous looking, but actually those are just, for whatever reason, sometimes we get those in our body, and those are just ectopic sebaceous glands. Okay, for whatever reason they form there, but they don't need to be there. They're just sebaceous glands that you normally have in your skin, but they form there in the mouth. This is an example of lichen planus. So here's the teeth. This is just inside the cheek on a buccal mucosa, and it doesn't scrape off like the fungus. And that's something you just have to watch, because sometimes, rarely, it can turn into a cancer, but that can be sort of painful and irritating. But for most people, it's just more worrisome than anything. And so sometimes you may biopsy just to make it feel better. But often a little treatment with a little steroid rinse in the mouth may help with that. And this is sort of a hand, foot and mouth disease, and it's caused by Coxsackie A virus, and it can cause sores in the mouth, but it can also cause sores inside on the hands, and the soles of the feet, and the palm of the hand. There you go. And so it's sores, but they're not like the target lesions that we've seen. So next slide. This is sort of an interesting thing. Again, that's why I like ENT. There's a lot of interesting things. So here's this fullness here, normal side of the palate. Here's the uvula. You're thinking, gosh, could this be an abscess? But really, they're not having a lot of pain. They're not having any fevers, not a sore throat. So what's going on? So we got an MRI scan. Next slide. And so here's the brain. Here's the throat. And look at this big white thing with a big old tumor. Next slide. So if you look at it in a different viewpoint, here's the back of the head. Here's the front of the palate here. This is the side of the throat here. It's coming in like this. This is a big old tumor. It's a benign pleomorphic adenoma. Unfortunately, those shell out pretty easily. So we made a little incision in the neck, and we put our finger in there, and it just slipped right out. And so it's sort of a good thing. And here's an interesting person. Someone came in, couldn't breathe through their nose very well. We looked in their mouth, and they had this thing coming down. Here's the uvula. Here's the palate. And then they had this thing coming down. So we looked in the nose. What the heck is that? This is normal anatomy. The turbinate inside the nose, the septum here. You saw this other stuff in here. We thought, what the heck is that? But anyway, we pulled it out, and that's what it was. So it's about 6 centimeters, and that's a polyp in the nose. So that's something you may find out. So that's interesting. Next slide. This is just someone that snores really big and big uvula, and not a lot of breathing area. This is on an adult or a bigger guy, and so to help him breathe better and sleep better at night, we took out his tonsils and trimmed his uvula a little bit. Next slide. This is sort of a demonstration of how to do it. That's afterwards. And he had a much better airway. Before, remember, he was just sort of like this, and now, if you know some of the Venturi and Bernoulli principles, it doesn't take much. You put the R to the 4th power as far as volume and airflow, and you improve it just by a millimeter or two, you make a huge difference as far as airway. So next slide. That's his healing now. Next slide. Next slide. That's it. This is someone that's had their tonsils out, and sometimes we've had parents call and say, what the heck is going on? I think my child has an infection, but they had their tonsils out a couple weeks ago, and that's just the healing up from the tonsils. So it's a moist scalp. Next slide. Now, this is just some people have a really big tongue, and so we'll take out a part of their tongue, and now we just sort of use a laser or coblation one, and carve out a little bit of a defect here, and put a stitch to pull it together, and that helps a lot of people. Sometimes other people have really big tongues, like the person that had the crenated tongue, and we'll take further up here and then bring it in just a little bit. But you have to be aware that there's important arteries and vessels to the sides. You can't go crazy on it. Next slide. Next slide. This is someone that has, this is a characteristic look of a basal cell carcinoma, sort of a centering umbilication is sort of depressed in the center and has a heaped up margins. That's like you worry about cancer. This looks like a cancer, but it's actually not. And but it can sometimes turn into cancer if you're not careful. But it's called a keratoacanthoma. They grow fast. So again, most cancers don't grow really fast. This grows really fast, and then it has like a center crust. So it comes up in a smooth thing, this crust, and then it often grows so fast that it outgrows its blood supply and it just falls off and it's replaced by a scar. If it didn't go away, though, you'd want a biopsy to make sure it's not cancer. The next slide. This is someone that had a basal cell carcinoma right here. And so a neat thing about ENT is we get to do sometimes some facial plastic work. And so, we were able to take this out. And a good thing that, I learned this from my residency. So this is sort of cool. When I was in my residency, I got a call late at night, 2 in the morning, and there was a prisoner that was brought in that was in some sort of a fight, but he somehow bit his lip off. Or someone bit his lip. I can't remember if he did or something. But he came in and just part of his lip was gone. And they didn't bring it with them or anything. And so I just sort of freed it up and I pulled it together, and over time it did great. And so I thought, when I saw this, I thought, if I could do that then, let's just cut out this cancer and pull this together, and that's what we did. So next slide.
So you've only done it once before, and you did it again?
Yeah, we did it again. So I mean, it's pretty easy. I mean, we do, honestly, when we say that kind of a thing, we do lots of variations of a similar thing. You don't have to do the exact thing. And we do a lot of sort of closures of, lots of times we'll have dermatologists that will do most procedures for that. So in fact, once a week, I work with a dermatologist, and they'll come and they'll have a hole somewhere, and we'll have to go pull it together, but anyway, so we do lots of stuff like that, so it's not like we never do that kind of stuff. So anyway, over time, she healed up nicely, you could hardly tell she had anything done. So remember I told you about sometimes it may be different than what you think. This is a guy who had a big beard, and he had this thing here, he was embarrassed about it, so he had this beard, he just wore it forever and ever, and he thought he just had an ugly looking cold sore. But it kept getting bigger and bigger and bigger, and so we biopsied it, it's cancer. You can see this cancer really goes like over where this redness is, and so we took it out. And remember we talked about the principle of stretching. The next slide. So that's after we took it out. Next slide. So there he is after we take it out. So what are you going to do? And so the problem about the mouth is you want to keep intact. Your mouth has this circular orbicularis oris thing. That helps you, talk and not have a leak when you talk, and when you eat, you don't want slobber to come down the side of your face. So it's very important. And so we had to somehow stretch that orbicularis oris and recreate that part of his mouth, and then later bring in some stuff to fill in the side. The next slide. So that's what we did. So in order to stretch it, we had to cut along here and not cut through the vessels or anything, but just to cut through the muscle fibers so we could stretch it. And then we pulled it around. And initially he had a small mouth, but over time he did well. But here's pulling in the flaps to cover the side. The next slide. So there he is. So it looks funny, but over time he did pretty well. So you have to keep that in mind. Next slide. This is a guy who's probably a nose picker. Don't pick your nose too much, but he had a cancer on the inside of his nose. And sometimes chronic trauma can create things like that. So what we did is to hide it only on this side, but we made a cut here. We just lifted that up, excised that cancer, but then we didn't want to leave it raw, so we had to put a skin graft on the inside of his nose. So next slide. So that's what we did. That's doing the procedure, how we approached it. So this is someone who chewed tobacco. There's the tongue, teeth. You see this in here. This is from the tobacco sitting here all the time. They get what's called leukoplakia. That is a pre-cancer condition. If they stop, often they'll sort of calm down or maybe resolve. If it doesn't resolve or persist, you got to take that out. That can be cancer. And here's someone, maybe a farmer, someone who's been out in the sun a lot, and they have leukoplakia on the lips. And so we would strip that off because that can turn into cancer. Next slide. This is someone who has AIDS, and this is a common thing in AIDS. It's a type of sarcoma called Kaposi sarcoma. It's sort of this typical purple, almost like a bruise area, and that's worrisome. This is a cancer of the uvula. Next slide. Cancer of the side of the tongue. Now, sometimes we say what you may see on the surface may really be the tip of the iceberg, and so we got a CAT scan on this person and got extension down into the neck, it was attached to the mandible, and it's much more involved. And so again, when I told you ET therapy, sometimes it's just basic stuff, other times it's really involved. And so this is a case we did in our residency. We're in the next slide. So you may not be able to tell, but this is the mandible, and we've cut the mandible here, and then you can't see where the other part of the mandible is up here, but we took out this part of the mandible, and we raised the cheek flaps up, and then you have to put in some sort of graft here, a plate or something. And then sew it back down, and that person ended up doing pretty well. They, of course, need some radiation chemotherapy. And probably, and I can't remember exactly, but I'm sure this is part of the carotid artery coming up right here. You can see the carotid bulb, the internal external carotid artery. But anyway, so it's sort of an interesting thing. You see all sorts of neat anatomy in ear, nose, and throat, head and neck surgery. So, next slide. This is a person that had a tonsil cancer. So again, this would be worrisome. So we've had people come to our office and say, gosh, we've got bad tonsils or a tonsil infection, and you go in there and go, like, that doesn't look like an infection to me, but you keep that in mind, so that's a cancer. Next slide. Another cancer of this tonsil, you can see, now that looks a lot different than the other side. Next slide. And this is, again, maybe tip of the iceberg thing. This is actually underneath the mucosa, so here's tongue, here's the side wall of the cheek, teeth up here. You see this sort of firm, almost like a little bit of a plaque underneath it. It doesn't seem like it's very ominous, but it really is. This is a cancer involving some of those minor salivary glands we talked about before. And so if you see this, feel a firm thing, that's sort of a worrisome thing. So next slide. And this is a person who had erosion of the hard palate. It can affect your septum. And often these are associated with lymphoma, so next slide. So this is a person that had a melanoma. So one thing about melanoma is when you take melanoma, you can't can't just excise this, because often it's already spread through the dermal plexus of lymphatics, and so it can be way out. So we usually take a big circumferential area of skin, and then we usually will take out the salivary gland here, because it has lymph nodes in it, and take the lymph nodes out down in here. And it's a way of helping us stage how far it's spread. And so we know right away if it's spread a lot of lymph nodes down here, it's not a good sign. But if you can find out that it's not, maybe you've done some good. Next slide.
So do you have to, like, is there any way, like through MRI, to find out how far you have to go, or is it just?
Yeah, that's a great question. You know, the problem is the MRI has, you know, it can't see tiny seeds. It can see a mass or an enlarged lymph node or something like that. But other than that, we really don't know. And so, you know, nowadays they'll inject this with a dye, and then they'll find out down here through like a little. It's almost like a little Geiger counter, where it's like a nuclear medicine type dye. And they can say, okay, this lymph node, this area drains down to this lymph node because this has got a lot of the dye in it. So they'll take those lymph nodes out and have a lot of the dye concentration and look. And if those lymph nodes are clear, then you can sort of feel better about it. The problem with melanoma is it sometimes can do skip lesions, so it doesn't always just go right to the next level. It may skip down. And so, but on this guy, this is back when I was in residency. We did an extensive dissection. So next one. So that's the excision of that. This is just to go to show you that you can do some big surgeries and still have them look pretty normal. So so we've taken out the thing. Here's his eyes. Nose would be over here, and we've raised a flap of skin up here. So we're sort of pulling the skin this way because we're going to go down here. Here's the ear. Take out the salivary gland. We have to find the nerves to the branches to the facial nerve because you don't want them to have the Bell's palsy. Then we're going to go down in the neck and clean out the lymph nodes. So next slide. So here's the branches of the facial nerve. Maybe some of you have seen that in your anatomy classes. That's sort of cool. So next slide. Here's the go back one. Here's the jugular vein. There you can see the purple coloration. Here's the 12th cranial nerve. So the face is going this way. The feet are down this way. So the hypoglossal nerve that goes to the tongue. This is the AMSA nerve that's going to go down to some of what we call the strap muscles that help move your larynx. Next slide. So somehow this like a flip. It makes it look like it's on the other side of the face, but it's really the same person. So we just put a skin graft. That's going to heal really nicely. We've sewed back those flaps, and he's really going to look pretty good at the end. Next slide. So that's it. Next slide. And this is, I talked to you about, how we saw the thyroid in kids. You saw the lingual thyroid in the adult. This is a kid that has what's called the thyroglossal duct cyst. And again, it's from, the thyroid hasn't totally, the thyroid descended, but it left a little cyst in that descent. And so that sometimes can get infected, and rarely there's been concern that sometimes cancers can grow on that, so that needs to be taken out. This is an unusual thing. In most adults, when we see a lump, we're thinking cancer. In kids, sometimes it's not. But this ends up being a branchial cleft cyst, which most of the time we see in kids, so it's sort of an interesting thing. So next slide. You can see this sort of cyst here, and so it looks different than a cancer. These are the vessels, jugular carotid, the airway's black, and so anyway, that's sort of interesting. So this is the last slide. It says, and I really believe this is the most important thing. So despite all that you're going to learn, you're just going to cram all this stuff in your head, and you're so worried about taking the MCAT, but really the most important learning that all of you are really going to learn is after you've become a physician. And as long as you have that in mind, that every time you have a patient comes in, you sort of study, try to figure it out, try to think of the differential diagnosis. It really is fun. I mean, medicine is great. If you can help someone figure out what the problem is causing, it's an exciting field. And so I think you guys are going to just love medicine. I love it. I know there's a lot of uncertainty as far as healthcare and how it's going to change, but still, medicine is a great specialty to be in, and you really can help a lot of people. So with that, if you have any questions, I'm sorry if I've gone too long, but I know some of you have classes here in a couple minutes. Thank you.
About tonsil stones, what is that, and what does my son get some?
Yeah, so tonsil stones, in the tonsils you can have, especially in adults, you can have these little pockets where the tonsil recesses a little bit, and debris can get caught in there, whether it be mucus or food particle or bacteria, But anyway, it can be sort of nasty smelling and tasting, and for some people it's really quite annoying to eat a little bit. So the different treatments are to gargle or use your finger to dig it out, or to ultimately take your tonsil out.
Well, we'd like to thank you for coming
Oh.
thank you, going to present comments.
Appreciate it, okay.
Thank you.
Well, good luck everyone, thanks for letting me come, appreciate it.